Thank you for joining us for the HPL seminar today. Everyone seems like they're in a good mood, lots of energy in the room, and a packed room, which is great, so thanks. Today, it is my pleasure to introduce our speaker, Dr. Kati Pasanen, who is an associate professor in the Faculty of Kinesiology here at UCalgary. She leads research in the Integrative Neuromuscular Sport Performance Lab, and her work focuses on injury prevention, neuromuscular control, and innovative approaches to performance and athlete health. Dr. Pasanen's academic and professional journey spans across physiotherapy, pedagogy, sport medicine, and athletic performance. She first began her studies in Finland, completing a sports-specialized high school program that integrated academic coursework with elite athletic training. She then went on to earn a BSc in physiotherapy, also in Finland, followed by a series of advanced degrees, including a BSc in sport medicine, an MSc in physiotherapy and health sciences, and an MSc equivalent qualification in teacher education. She then completed her PhD in injury prevention and sports medicine at the University of Tampere in Finland. Dr. Pasanen is also an accomplished multi-sport athlete. She has competed in cross-country skiing, swimming, track and field, and spent many years playing ice hockey at the highest league level in Finland. And in her case, her range, if it wasn't impressive enough, it's surprising that the only sport she's competed internationally in is show jumping. And yes, it is with horses. Today, Dr. Pasanen will be presenting her talk titled Real-Time Biomechanical Feedback, a New Approach to ACL Injury Prevention. Thank you.
Thank you so much. Yeah, education in Finland is free for everyone, so it's quite easy to go to school after school and again and again and again, and then you have more time to play sport. And yeah, don't know, but thank you so much for having me here. I think it was 2 years, 6 months ago when I was giving my previous talk here. And we were then starting the study that I'm gonna be speaking about today. So now I have some preliminary results, which is really cool. And regarding horseback riding, does it work? No, I have to use this. I have a proof for you guys. Yeah. I think this was 1986, so a few years ago. This is me, 16 years old. Back then, I really thought that I'm gonna be a professional show jumper. I had 2 own horses, and actually I also had a few sponsor horses each year. And I was so much focused on this sport. I did play hockey already. And as I said, I thought that I'm gonna be a professional rider. Then my dad said no. And I started to focus on hockey and my education and schoolwork. So yeah, that was me then. And Matt and I, we've been leading this lab now for a few years. We started to build our lab right after the pandemic, and we've been working very closely with Dino's teams. And as we all know, Matt's research is focused on muscle strength and power, and I'm more or less focused on movement analysis. And in this talk, I'm gonna be speaking about this study that we studied then about 3 years ago. Preventing ACL injuries in female sports. However, the preventing here is mainly for funding purposes, because we are not going to carry out any randomized control trials. We are focused on movement quality and knee loading. And we have a 2-center study, so somewhat similar study in Norway, which started a year before we were able to start here in Calgary. And this is Lasse. He's a physiotherapist as well and PhD student supervised by John Crosshow. And Reed is my PhD student, physiotherapist as well. And as I said, it's somewhat similar study setting in both countries. And why we are not doing randomized controlled trials is mainly because it's super expensive and time consuming and may not be relevant all the time. So this example here is from Sweden. So my colleagues in Sweden many years ago carried out this so far largest randomized controlled trial focused on ACL injury prevention in youth female athletes. So they were soccer players, more than 4,500 participants, more than 300 clubs, 7-month intervention focused on strength training using own body weight, jumps and hops. And they saw 7 ACL injuries in the intervention group after this intervention period and 14 ACL injuries in a control group. Okay, the finding was significant, but it's a huge amount of work. And this type of study is expensive. So therefore, we have decided to focus on more feasible approach here. So we want to focus on movement quality, movement control, biomechanics, and evaluate how training maybe can change these factors. And our specific and primary interest is knee abduction moment time during sport-specific maneuvers. And maybe after these smaller studies, we may be able to carry out a pragmatic clinical trial, but it will not be anything like this because it's just too much, I guess. I don't have time for that. I have to retire at some point. But some background, I have mentioned this study earlier. So I've been working with the Norwegian research group for almost 20 years now. And this is the biggest study we have carried out so far. So our aim was to investigate risk factors for non-contact ACL injuries in different team sports. And in Norway, they focused on women's handball, soccer, elite level. And in Finland, we focused on floorball, basketball, and then we had a few teams from hockey and volleyball as well. And we also included male players. So in Norway, they were all female, but in our study, we also had male players. And then over these years, we saw 64 non-contact ACL injuries in Norway and 27 in Finland. Interestingly, we didn't see any non-contact ACL injuries in males. So they were all females, those injuries that occurred. And this was that test protocol we were using. So we tested these players before each season. So basically we were doing baseline tests from April to June, sometimes longer. And those were full days testing. So it took about 6 to 7 hours for one player to complete all these tests. And these tests we included here were based on the knowledge we had back then when this study was designed, 2005, 2006. So there were tests measuring their muscle strength, balance, anatomy. We did some blood tests, but the central piece was movement analysis. So we then started to design some sport-specific cutting drills and cutting tests. And we also used some generic drop jump tests as well. So these were the key areas, these movement tests here. And then after the testing, we collected prospectively information of injuries throughout their following season. And then they did the same tests again. And this went on and on and on and on. And back then I had a big lab. I think I had 30 students and staff members working on this study only, because not only the testing was hard, but also the data collection throughout the season. So injuries on a weekly basis, exposure hours, game hours, and so on. So it can be time consuming to carry out a cohort study as well, not only randomized control trials. So what have we learned? Mainly our results have shown that most of those suggested risk factors were actually not related to ACL injury risk at all, not even. However, it was good practice for our students. Many papers, many theses. So there was a reason for doing this study. And it's a funny thing when you conduct this type of study, you have such a huge data set that it will never end. We are still writing papers. I should finish 2 papers during this holiday season, if I have time. So it will never end. But we did find something, and these are the key findings. So the leading risk factor for future ACL injury, surprise, was previous ACL injury. And then also for second ACL injury in adult cohort, greater standing knee valgus angle was associated, but we didn't see that in youth cohort. Then in youth cohort, stiff landings and high ground reaction force and drop jump landing was associated with increased risk. And then in both cohorts, high CAM during sport-specific catching tasks was associated with future ACL injury. So those are the key findings we saw in this youth study. And even though we have identified some associations, we still need to focus on exact injury mechanisms and injury situations, because injuries are caused by mechanical loads. So we need to understand those loads a little bit better and maybe find ways to control them during those high-risk movements. So let's take a look at the ACL injury mechanism. We all probably know this very well. I see so many students from my class here, and I have used some of these slides earlier. So these are the typical injury situations where we see non-contact ACL injuries: sidestep cut, quick change of direction, and landing from a jump. Majority of them, in both females and males, occur in non-contact circumstances. So it means that the injury is not caused by a direct hit to the injured leg. There can be a contact somewhere else, shoulder to shoulder, for example, but it's not caused by direct contact to the knee area. Body weight is on one leg, small knee flexion angle, so knee is relatively straight. And then there's high impact force. And then knee valgus and internal rotation occurs. And there are more and more studies now focusing on timing of ACL injuries. I just saw 2 recently published studies focused on professional soccer players, male and female soccer players, showing that ACL injuries typically occur early in a game. So when players are jumping higher, running faster, performing more faster and faster direction changes. So maybe the intensity is playing a role here, maybe. But talking about the loads, so this list here includes the knee loads and associated kinematics during single leg athletic movements. And during those movements, these four loads on this side, on the left side, can create the highest loads to ACL. And on the right-hand side here, we can see the kinematics related to each one of those loads. And CAM is specifically interesting because it can generate all these three kinematic responses here: knee valgus, anterior tibial translation, and internal tibial rotation, and all those can strain ACL. And this is how it's supposed to suggested to go. So here we can see a nice straight knee alignment. And in the second figure here, we see a valgus loading, and there's compression load on the lateral side. And valgus itself is fine. So if I do this movement 1,000 times, I'm not going to do any harm to my ACL. But if it occurs at the same time and with a high impact force during landing, for example, there can be a large compression force on the lateral side, which then can push tibia forward. And when tibia is pushed forward, it also rotates, because the center of rotation in a knee joint is on the medial side. So that's why anterior translation and internal rotation are combined. And this can be even more harmful in those individuals who have very steep tibial slope, lateral tibial slope. So normally this is somewhere between 6 degrees and 10 degrees. But in these examples here, we see 30.5, 5, and 12.1 degrees. So then the femur can push tibia even more forcefully forward in this type of single leg landing situations and cutting movements. And that's maybe the reason why, according to some cross-sectional studies, those who go through ACL reconstruction, we see more these individuals with steep tibial slopes there. So it's probably related to the risk of ACL. Also, biomechanical studies have estimated that ACL injury rupture occurs in 30 to 40 milliseconds after initial foot contact. And interestingly, CAM peaks within the same time window. And to reduce CAM, we need to either reduce the magnitude of ground reaction force or its moment arm. So can we change something here? Can we change the mechanism, the chain of events here? Maybe we can focus on double leg landings only and avoid one leg landings. Well, maybe it works sometimes, but there are majority of athletic movements are single leg movements. It's hard to run and change direction and keep your both feet on the ground at the same time. Maybe we should focus on soft knees. Again, it can work sometimes in some landing tasks, for example, but many athletic movements require stiff knees. Otherwise, you are way too slow. But there are something that we believe that we can change. We can find some strategies to reduce impact forces and knee moments. We can control knee valgus. We can maybe control knee internal rotation as well. But most of all, we should focus on these movements and these situations. And the current injury prevention programs are not focused on sport-specific movements like this. Majority of them include just generic exercises, which is good. They are good. Walking lunges, squats, different types of hops and jumps, planks, important exercises, but there's lack of sport-specific movements during which ACL injuries typically occur. Also, we need to focus on this time window here. What is going on before initial foot contact and at the initial foot contact? If we are focused on here, the ACL is already gone when we see a clear valgus collapse. And I have changed the way I show this time window because I have noticed that some of my students in my class, not you, Mitch, thought that 40 milliseconds is same as about half second. Where it's a little bit short time. Yeah, so it's a very, very short time period when it occurs. That's how we believe it goes. Okay, but there are many studies showing that injury prevention by training programs, neuromuscular training programs is possible. And this just recently published review studies show that 61% of ACL injuries can be prevented by exercise training programs. But note that there were only 4 studies in this meta-analysis. I am one of the authors. And one of those studies was Walden's and others study from Sweden with 4,000 something participants. And the second one was from the US, Labella and others, and they had I think they have 1,400 athletes there in their study, but the 2 remaining studies were just small cohort studies, unpowered, and there's clearly lack of studies showing the results of these type of exercise programs focused on ACL injury prevention. But still, I mean, this is a good start. The problem with these programs is that they have been effective in a research setting, but when the study ends, teams and athletes and coaches, they stop using these programs. And the main reason what we hear over and over again is that it's boring. It's not sport specific. It's not athlete specific. It's not meaningful for me or my sport. So we need to consider this very carefully and try to provide more meaningful programs for our athletes and teams. And also the big issue is that there's only small number of studies that are including exercises that are somehow related to those real world playing situations. Okay, so then how to reduce knee loading during these high-risk movements? That's what we've been working on during the past 3 years now. So our goal in both in Oslo and here in Calgary is to identify those athletes who have increased knee loading during sport-specific game-like movements, like cutting and landings. And then we provide them individualized technique cues. And then we evaluate how do they like those exercises, and can they change their technique and reduce their knee loading during those sport-specific high-speed movements. And so far we have been working with basketball, soccer, and field hockey, women's teams, diagnosed teams. And here you can see a few examples of those tests. Some of these tests we already designed earlier when I was still back in Finland. But then we have also some new tests here. These are for soccer, these examples here, and this is from the first study year. because we are not using the turf yet. So during the second study year, we use the turf here. So there is a 180-degree pivot turn, which starts with a quick pass, and then athlete speeds up to the force plates, turns and returns back where they started. And then there is different types of 90-degree cuts. This one here is that athlete runs towards the force plates, and then they need to react what the assistant there is doing, and they turn either to the left or the right. And the last one here is the heading task for soccer. For basketball, we have a rebound task as a sport-specific landing task. So this type of tests we have been using. And some very early results regarding those tests. So here we can see 180-degree left and right, 90-degree turn left and right. And then we also have used very generic drop jump, single leg drop jump test here left and right, and then the heading task or rebound task. So we have both soccer and basketball players in this data here. And as you can see, we saw way higher loading knee abduction moment, which is normalized to a body mass compared to generic drop jump tests. And drop jump tests are still widely used as a screening test before the season starts. So this makes me think that does it really give any ideas about knee loading among those athletes compared to the sport-specific tasks here? But as we saw the higher loads during those cutting tasks, we decided to focus on those tasks during the second study year. And for this study year, we received a very neat real-time feedback system that I'm gonna be speaking about in a minute. And we have been working on these two studies now. The first one was submitted, actually the revision one was submitted a few weeks ago, and now we are working on this intervention part. So first we wanted to see how these technique cues work and can we really reduce knee loading by providing these technique cues for athletes. And then we also wanted to see if specific technique training throughout the season can help athletes to reduce their knee loading during these sport-specific tasks. And this is a little bit busy slide, but I will walk it through slowly. So these are here results for one athlete. And on the left-hand side, you can see results for 180-degree cuts or turns. And then here we can see 90-degree cuts. Come is up here for 180-degree turn. And here you can see how come in this athlete as well, it peaks there around 40 milliseconds. Regarding the 90-degree cut in this athlete, it peaks a little bit earlier even and goes way higher. But here the gray bars are the first trials for left leg before feedback. And black is first trials for right leg before feedback. And then we see this athlete received foot strike angle cue, and she was able to reduce a little bit knee loading on her left knee and also in her right knee here. And these are technique variables here. This is a foot strike angle. Then we have a trunk lean for 180-degree turn and knee valgus angle. And for 90-degree cut, we have also foot progression angle here. And these two guys have designed this app, so we are just using it. So they designed this app, and I flew them here in April 2024. They stayed here for 10 days. And we did some pilot testing then, And when we were ready to go, we started to recruiting athletes again and started our intervention study. And more details about those cues. So we've been focused on these 3 cues in Calgary so far. Foot strike angle first, so we asked them to land softly, more on your forefoot instead of their heel. And then some of them will receive the foot progression angle. So we ask them to point their toes forward rather than inwards. And then the last one is for 180-degree turn. We ask them to keep their upper body weight on the inside leg here, because most typically we see ACL affecting the outside cutting leg. So by keeping your upper body weight here when you turn, you will unload your outside leg and maybe reduce the knee loading that way. As a coach, this is also the way how I teach my athletes to do this type of 180-degree turns, because it's faster way to turn. And yeah, we saw up to 50% reductions on knee abduction moments after these cues. And another busy slide, but this is for soccer players, and this is only for foot strike angle cue. So from here we can see that 25 legs receive this cue. So before the feedback, time was 1.05, and after feedback, it was below 1 there, and it was significant difference. And same here for a 90-degree cut as well. So the athletes, they may receive different cues for left and right leg, and also different cues for different tasks. So one athlete may receive a little bit different cues for 180-degree cuts, 190-degree cuts, and also there can be difference between their left and right leg based on their performance during those pre-feedback trials. This is from Norway. So handball is different sport, and they are using different types of tasks and cues as well, or at least some of those cues are different. So in handball, they are standing there 8 meters from the force plates, and they speed up towards the force plates, and then they receive a pass, and then they perform a very quick fake cut maneuver. And I think it ends up with scoring the ball, but it's a little bit longer distance. And they are also using the soft landing cue here, land on your forefoot, and then they are focused on knee valgus, avoid your knee falling inward. And then because this is more like a little jump or leap to the force plates when they receive the ball, they also can be asked to reduce the jump height when they do the maneuver. And they saw up to 17% reduction in knee abduction moments after those cues. We have also carried out interventions, first in Norway. I traveled there in 2022, May, when we started this, and we just wanted to test if direction change, technique focused, strength focused intervention could reduce knee loading after 9-week intervention. And it was supervised training, one size fits all, meaning that everyone received exactly the same program. So it was team training, group training. And surprisingly, we didn't see any improvements, no reductions in knee loading, no improvements in strength, even though it was heavy resistance training for lower limb muscles, focused on hip muscles and calf muscles. So then in Calgary, we decided to do this a little bit differently. And we focused only on cutting technique. And we asked the players to focus only on those tailored, individualized cues, their own technique cues during those supervised cutting technique sessions that we provided them. And again, it was not a warm up, so they did their own warm up before that, or sometimes this was carried out after the exercises, after their practices, so that they were able to do full speed running, full speed turns without any injury risk during those turns. And then we saw some improvements here, and also the adherence was good compared to Norway, where the adherence was good. And just preliminary results here. So here we can see 180-degree cuts. This was only for soccer. So we have baseline test here, baseline CAM before feedback, and then right after feedback, they were able to reduce their loading a little bit. And then after the intervention, it was still lower here. And when they did their post-season test, we didn't remind them about the cue they had. So we just asked them to do those tests we've been using. And same here for 90-degree cut. So it's still lower here after the intervention season compared to the baseline results here. So it's promising, I would say. However, the main limitation here is that we don't know how do they perform in real world. They are able to maybe remember that, oh, my cue was that. Now I have to focus on my cue and my cue only when I'm doing the post-season test. So it would be interesting to see in the future. For example, Bill said to me that we should maybe use the markerless motion capture and see how they perform during their practices to see have they really changed their technique. But that's some thoughts for future studies. We also asked them to complete some questionnaires after the intervention, and majority of them had quite positive thoughts about the intervention. And they thought that it would be important to continue doing this type of exercises during the following seasons as well. Then this text was one of the players. The player sent this text to her coach that she got 40 on the beat test, her personal best ever, I guess. Who am I? I swear it's from the ACL turning. That's how they named that, ACL turning. And I think this is an important message we need to tell to coaches and athletes that when you do this type of technique training, you can improve your performance if you focus on those technique cues. Okay, and then this is my last slide, I guess. So future directions, we would like to carry out somewhat similar studies in different sports, include more sports, volleyball, for example, also design more sport-specific cutting and landing tasks. We have some ideas for other cues as well, different technique cues. So far, we have focused on adult athletes, so it would be interesting to see how it works with youth sport, where the ACL injury risk is high. And then, of course, both females and males maybe in the future as well. And this could be something that we should consider for monitoring athletes who are going through their rehab and when they are returning to sport to see where they are at after their rehab period regarding their knee loading. And maybe one day we will be able to carry out a pragmatic trial. For example, Matt and I, we have been working with Amanda Black, who is now leading a study in different universities, collecting information about injuries. So maybe we could find from that collaboration other universities who would like to do something similar. But it would probably not be a randomized control trial, it would be based on the settings, what they have there, do they have a similar motion capture opportunities, and can we bring our feedback system there? But there are some opportunities for future collaboration for sure. And these are my key messages. So overall, we think that ACL injury prevention should focus on biomechanics that contribute to ACL rupture. And we should also focus technique drills that aim to improve the cutting and landing technique and reduce knee loads during those movements. And as I said, this type of approach may be useful in university sports settings, but it may be not the right approach for community sports. But in universities, it might be working well. Thank you so much for your attention.
With that, the floor is open for questions. Who would like to start us off? Bradley.
I wanna understand a little bit more the abduction moment thing, because in OA, we use the term cam all the time, but actually
It's the difference.
it's external knee adduction.
Yeah, and this
knee
is
Adduction moment. And this, sorry,
external knee abduction.
external knee abduction.
Yes,
Okay, now I get it. Cause
Yeah.
I was like, I think the moment should be adductor, but you're talking about the external.
yes, yeah.
You
And
know
we've been,
why?
yeah, I know, it's confusing sometimes. And it's confusing, when you read, papers related to ACL injuries and they are, yeah, we see both,
Yeah.
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 But this is what we've been using with Norwegian group. And in our papers, we only, well, sometimes it's the reviewer who has asked to add external cam. And maybe we should use that, all the time.
I think as long as it's clear, it
Yeah.
doesn't matter, but, when you compute that moment, do you do an inverse dynamics analysis and then flip the sign? Or do you like do something else? Do you look at the orientation of the ground reaction force vector relative to the knee joint? Do you know how
Yeah,
those
because
are calculated?
I don't know little details. I'm not a biomechanist, I'm a physiotherapist. Trust me, I'm a physiotherapist. I can ask someone, but right now, I don't know. It's Reed here. My student, no.
My other question is about sex differences. You didn't really talk about it yet. I'm assuming maybe you did, sorry, I assume you're exploring that there's a bigger risk in females, right?
Yeah.
Of ACL. Do you see higher CAM in females, or are there other things
Very good
that can
point.
explain the higher risk in females apart from CAM?
We are just writing a paper from the Norwegian data. And actually based on the literature review for this paper, we saw that there are studies showing that external cam is higher in males compared to females. But then there are studies showing that females have higher external cam. So we see both. I think it's more task specific maybe. And still majority of studies have been using vertical drop jumps, not so much cutting maneuvers. But in Norwegian study, it's another study where we also included male players. And it was that this particular task they have been using in this project as well, male players had higher CAM compared to females.
Is there anything about female anatomy or biology that would that would give a female a higher risk of an ACL injury for the same can?
Of course, females have, overall, we tend to have more valgus. So the valgus angle or position itself is clearer, not in every individual, but it's bigger usually. I think that's maybe the main difference.
And we're kind of.
Just kind of follow up on that.
Yeah.
You were talking about tibial tilts playing a key factor in ACL injuries. That do women on average have a higher tibial tilt than males?
I don't know, do we have that kind of data, but because those studies are based on, cross-sectional study designs. So they are athletes who go through the surgery, and there's more females going through ACL reconstructions than males.
So that'd be interesting. to
Yeah.
look into.
But then there's also other anatomical differences, so the ACL itself is smaller in females compared to males. So maybe it's weaker for that reason.
Ariana and then Venus. So you mentioned it would be hard to follow the techniques that you've given in like real sports settings because they're like doing all these things. Have you thought of using like tape or shoes that would kind of like force the body to do the corrections you've given it?
Yeah, maybe in the future we can use something, in a real world and follow how they are performing there. But so far we haven't been doing anything around that.
Yes.
You mentioned stiff landing. I don't, what does that mean? Like to me,
Good question, yeah.
And then you talked about soft landing and knee loading. So what do you mean by that? Is that the amount of activation of the muscles that are surrounding?
Yeah, so the stiff landing is actually a finding from my own studies. And so we used a vertical drop jump test. So they jumped off the box, landed, and then jumped up as forcefully as they could. And stiff landing in this type of landing means that they land with straight knees. Straight knees, yeah, so they don't do not much, eccentric work with their muscles. Straight knees, and then they try to jump off again.
And soft landing?
Soft landing would mean that they land just soft, yes, with soft knees.
And would this it change the the performance? Like what do you think about when it's they gain in speed or they lose in speed when they change their behavior when you give them this cue? Because you were talking about just how they change, but and how they perform after that. You didn't say anything about that. Like about their performance after they have changed their behavior.
Yeah, so for the performance perspective here, they had to use exactly the same speed. So that was measured. So the reductions we saw was not because they would have, running slower or something like that. It had to be the same speed and same effort every time.
And how did they receive the cues?
First they performed the baseline trials, and then we did show them this is what we show them, that okay, these are your so after they have completed these baseline trials here, and we based on their performance, we provide them one cue. In this case, it was a foot strike angle. So we asked this player to land softly on their forefoot rather than heel. And she was able to change the technique, and then we did show them that, look, now you are doing well here. This is way better now. Or if it was another cue, we did show that, okay, now this is, can you see it's way better now?
Okay,
Yeah.
so after they've done their run, so you talk to them, you say,
Yeah.
do this, do that, and then they try.
Yeah, yeah.
Okay.
And
So
usually,
it's like Judy, like you're talking to them, oh, no, change this and change that. No.
yeah, so, and we also, so we gave them a cue, and then they were able to practice that a few times. And when they were ready, they did the same trials again.
I have one follow-up before I let others ask one. So how quickly were they able to get used to these cues and implement them right away after? Like, did it take a really long time or quick turnaround?
Yeah, so most of them, well, actually, the most commonly used cue was this foot strike angle. So that was pretty easy for them. So they were able to change almost immediately. Foot progression angle, it was a little bit more tricky, and I think it might be related to their anatomy. So if they already have a hip anteversion, so that their hips are turned inwards, so, and this is their normal position, then it might be a little bit hard to turn your foot and toes forward. So that was a little bit trickier. And the trunk lean, this was harder. This was difficult because it's not a simple one joint change. It's whole body that you have to change, and timing as well. So I think this is a very useful cue, but it might need a little bit more practice time before they are able to change that.
Bill and then Beth.
Just question on the cam, how do you determine the threshold? So when they come in, are you just always getting them to reduce it? And is there a point when it's like, it's good enough, you're already at a low risk, this is the value you get to?
Yeah, so the values were based on studies in Norway and also our first year results. And I don't recall what was it, but we basically, even though it was low, the cam was low, we still asked them to change to see can it go a little bit lower. But in Norway, they have done it differently. So if it was already low, below the threshold, they didn't ask them to change anything. But we did it a little bit differently here.
And then just the follow-up, so you looked at the knee, front knee joint loading. Did you look at how changing that or reducing that affect joint loads at the other joints, like the ankle joint?
Yeah, we have done, we have all that data. I don't have it here, but yes, we can check that, yeah.
Did it increase the, or you don't know yet?
I don't know yet. We have just started to do this. And we have the same data from Norway as well, so we can check other joints as well.
So you assume that the ACL injuries are primarily a mechanical problem. Your data that you look at are mechanical data. Have you ever thought about other possibilities that the ACL injuries could be explained with?
I think my opinion is that mechanical loads are key factors, but there are many other factors either increasing or decreasing the risk. And
Could be more specific.
I think my personal opinion is that there are many, for example, anatomical factors that we have been discussed here that can make ACL a little bit weaker and more injury prone. But these are just, scientific guesses. We don't exactly know that.
Yeah, the other one are scientific guesses too.
Yeah, they are all. You're right.
I just have the gut feeling that you missed something.
I think we are missing many, many things. Yeah, I absolutely.
You mentioned that ACL injuries occur more frequently in the beginning of the game.
Mhm.
And I've read some literature that suggests that's the case for a lot of sports, for example, like in football and American football. But I still get grants that I'm reviewing that come across my desk where people are saying they're gonna explore relationships between neuromuscular fatigue because fatigue could be playing a role in ACL injury. So, like, what's the current state of knowledge around ACL injury? Is that old news now? We can put this aside. ACL injuries don't happen because of neuromuscular fatigue, or is there still a place for neuromuscular fatigue in ACL injury?
Yeah, for sure. I don't think that they occur exactly identical situations every time. And there are many, many different factors associated, related to playing surface, footwear, fatigue, anatomy, all kinds of things. Also, there has been a lot of discussion about ACL injuries that is it really a pure sudden onset injury? Because maybe those athletes have been doing those movements thousands and thousands and thousands times, leading to some, micro traumas. And then one day, it occurs.
Have you done the study where you fatigue people and then looked at the CAM? Yeah.
Not yet.
I have a question about the real-time feedback system. Is the input just motion capture data and does it just basically give you those graphs that you were showing on the slides, or can you talk a little bit more?
Yeah, so it
details?
provides all variables for us in 10 seconds. Way more than on those graphs. So we can find all results from there, but that's what we show this is what we show to the athletes.
And so the app is not giving the cues, it's basically quickly processing your data and giving.
Yeah,
you
so we
results,
do
and
the,
then
that's right, yeah, so we see the results from here that, okay, maybe we should focus on foot strike angle now, and then we give the cue. Or maybe we should focus on something else, yeah.
Ashley?
Yeah, Kati, the study that you mentioned that did the heavy resistance training, but didn't find anything. How should that impact CAM? And I'm just wondering, because we also hear like the gendered environment such that female athletes aren't exposed to as much strength training, like from a young age. So there might be a deficit in strength that may also lead or contribute to ACL risk. So how do you expect strength training to impact them?
Yeah, so that was another guess that we had. So the strength training was focused on hip muscles and calf muscles. Hip muscles for that they would maybe be, we thought that they would be able to control their knee alignment better during those movements without knee buckling inwards. So better activation here. And calf muscles so that they would be able to do softer landings.
So did they get stronger, but nothing changed?
Nothing changed, yeah,
Okay.
yeah.
Micah, thank you for your talk. Also another question about some of this real-time feedback. I'm curious about any literature or potential work regarding taking some of this biomechanical analysis and predicting ACL, like future ACL risk. Could this be used? Has any other group kind of worked on that, or that's something that you could maybe consider integrating in?
Yeah, I'm not aware that any other groups would be using exactly the same, for example, tests we've been using or same approach. That is, of course, something that someone should consider. It's not me. I've done my risk factor studies already. Maybe you. Well,
It's very, very nice and learning a lot.
thank you.
Why is prior ACL injury the best predictor for future ACL injury?
Yeah, that's an interesting one. Because it can be either the same leg or the other leg. We have some data and we are now actually, we just submitted one paper where we compared knee abduction moments among those who had a history of ACL injury and healthy female athletes and also male athletes. And female athletes tend to unload their injured leg 4 years, even 4 years after reconstruction. Which is, you would think that, well, then they should be, safe. They are unloading their injured leg, but still they have a higher risk for future injury. So this data may not give us all the answers, as Bena said. This is just guessing things. Maybe they still have changed something that is increasing the risk.
Maybe it goes back to what Benno was saying, that maybe the biology plays a role, the structure.
Yeah.
If you just have a smaller cross-sectional area in your ACL, and for the same moment, you just carry much earlier than another person, or just material problem.
Mm-hmm.
That your ACL is just not as strong for something. The other question I had is, I try to look at your things. If you go back to the forward striking and the leaning in there, the preventative measure. And
This one.
Exactly this slide, So if you go to the, you don't want them to hit with the heel, but you want to hit with the forefoot. And I like the figure that you actually have, because I think it's absolutely correct that if you land in the heel, you stick out your leg more, which means you make a longer step. So if you need, whereas in the other one, if I want to land on my heel, I cannot stick out my leg.
Mm-hmm.
Because I cannot land on my toe if I do that. Which means if I have an opponent in front of me, and I want to get around that opponent and make the big step, I probably have to stick out my leg. So it's nice in the lab.
Yeah.
And then the same is the leaning in. I want to get around an opponent. I want to get away from the opponent. And then once I'm by him or her, then I lean in. But if I lean in from the very beginning, I'm a soccer player. Everybody knows where I'm going. The whole idea is that you fake where you're going. So you don't lean in before then you land, because then everybody knows where you're going and you're never going to get by your opponent. So I wonder, in a play situation, how realistic that actually is.
This one.
And the forefoot versus here.
I start with this one because this is my favorite. This technique is not for all direction changes. You're right. When you want to fake the defender, this is not for those situations. This is when you are running and you are watching, you are reading the game, and then something happens there and ball is all of a sudden there. Then you do a quick direction change. I was able to, by the way, do this way faster, but now I have a new knee, so I'm doing just this speed now. So it's for different situations, this. So when you have to turn quickly and continue back this way, when you are doing a fake movement, then it's more like you go there first and then you continue this way, right?
So I was also thinking about the knee abduction moment. Because if I assume that the performance is exactly the same, I'm coming in there's a direction in one direction, then I want to go out in another direction. Then I need a certain impulse in that, from the lateral to the medial direction. And if I'm doing it exactly the same, I have the same impulse and, then I see about three possibilities how I can change that. I can either have the impulse distributed over a longer period of time. So my incoming velocity, my outcoming velocity is the same, but I'm actually needing a little bit more time on the platform, or so then the performance is probably not quite as good to go to another size. Or the other thing is, I'm bringing the knee closer to the ground and I make the moment arm between my medial force and my knee smaller. I'm not really sure how that goes. Or then you do what you're saying there is that you go on both legs and you distribute the load more. But then, then you lose that advantage of going around the person. But as you said, you can use it for the thing. But at the end of the day, if I have a velocity in this direction, a velocity in this direction, the moment I need to produce, the force that I need to produce, the impulse that I need to produce in that direction needs to be the same. So when you probably talk not really about the impulse of the force or the abduction, or you probably talk about the peak.
Yeah, peak.
Is that correct?
Mhm,
Just
peak.
look at the peak.
Yep. That's right. And so the foot strike angle, that was a very good point, Walter. Because we don't want them to be in this position here. We don't want to cause ankle strain.
That's what I was thinking.
So this is where we are aiming.
Still, you can't reach as much forward because your lower limb.
Yeah.
Otherwise, I want to come back to strength training as well.
Okay.
Because I'm going, people who are really quick are usually very strong, and they're very quick because they are strong. And of course, the stronger I'm getting, the faster I probably can change direction, and I'm producing a greater force and I'm producing a greater cam. So my hypothesis actually would have been that when you do strength training, they get substantially stronger, and you have a greater cam rather than a smaller. But that didn't happen, I guess.
Yeah, it didn't happen here, but I agree with you, and I think that the one big issue here, why we don't see ACL injury reductions in females, is maybe that our female athletes are getting stronger and faster and better every year, specifically now when there's more and more, high quality training in female sports as well.
And isn't that the problem with sports injuries?
Yeah, it is.
The athletes that I've known, including myself, you train a bit more and a bit more and a bit harder and a bit harder. You always work very, very close to that line where you get injured, and when you're fitter and fitter and fitter, you can do more and more and more.
And when you are better and better, you will get more game time. I mean, you are playing more and more and more and more intensive games, and it will never end.
So when you have an ACL injury through a cupping movement with no contact, where does the ACL tear? Is it a rupture out of the bone, or is it a mid-substance failure?
You typically mid.
So it's the ACL that fails.
Typically,
The insertion that fails. Which is
All right, any last questions for Kati? No one has gone up? You want to thank her for that one?